Good afternoon, guys. Thanks for joining. We'll go through the fairly difficult to understand at times topic of heart-lung interactions, and we'll obviously have this with a particular relevance towards the critically ill. So we'll start off with a simple case. We're going to start off slowly and build up in complexity, all right? So this case is of, forgive me if you've seen some of these cases in the RV talk that we gave, because obviously this relates to it. But we did show this case back in April, I think it was, so forgive me if you've seen them already. This was a morbidly obese gentleman who was having surgery. He was sick with sepsis, but was on the ward, and he was with some infection, soft tissue infection, and went to surgery to have the look at the soft tissue infection. He had some sedation, was intubated, and immediately proceeded to have a cardiac arrest. And when we look at his X-ray, we can see that there's some biobasal atelectasis. And what's interesting though is the couple of days after he was in our ICU and we got a chance to have a look at him, we still weren't absolutely certain about what the cause was of the cardiac arrest when I took over him on sort of day 3 or 4. But you can see that in the subsequent few days, he got acute renal failure as well as having this unexplained cardiac arrest. And when we finally had a look at his heart, and you can see here that he's got a significantly dilated right heart. This is where the penny starts to drop. And when you've got unexplained things like metabolic acidosis, acute renal failure, unexplained hypotension, or in this case it was a horrific cardiovascular collapse, and LFT derangements, coagulopathy, things you can't explain, it's always worth thinking about the right heart. And this one you can see a beautiful example of someone who's on a considerable amount of cardiovascular support with moderately high ventilator requirements, and you can see that the cause of this is right heart dysfunction. This is an example of cor pulmonale. And remember, cor pulmonale is a diagnosis made both by echo as well as clinical signs. And the clinical signs are of the right ventricle failing, it being unable to support the RV output. So you need a considerable amount of catecholamine requirements to support a blood pressure or cardiac output, and you've got signs of venous congestion. And we were lucky enough to have an echo of this guy from a few months earlier. And although this guy's not easy to scan, this guy's 250 kgs, but you can still get images that are able to be interpreted and are able to help us with the diagnosis. And here you can see, in particular, I've got it was on the 6th of January that we first took these pictures. Those are the top ones, and the bottom ones are the ones that were taken about 6 weeks earlier in November at the end of the year before. And you can see the difference. The RV is markedly bigger, and the septum is markedly flattened. What's interesting is you have a look at the one in the November one, and you can still see that we've got an enlarged RV, but it's not off the charts, and you've got a little bit of a septal bounce. And it looks to me like potentially one of those might be worse during the respiratory cycle. Sorry, just admitting another one. Because this guy was difficult to image, I wanted to double check this and also to use TOE to help guide insertion of a pulmonary artery catheter that I think are useful with these guys with RV failure on a lot of catecholamine support. And this is just to show an example of what RV dysfunction looks like on transesophageal, because we don't have a lot of objective measures to use. I guess you've got fractional area change. You've got your eye to assess RV dysfunction in TOE. But we don't have really things like TAPSE and stuff like that aren't really validated. But what we do see here is that the RV looks bigger than the LV. You've got that interventricular septum that's pushed over to the left. Can you see my mouse, by the way? Is that okay? You see the mouse? Yeah, good.
Yeah, we can see it.
And this RV free wall, it's almost like it's just sort of rocking. It hasn't sort of got a nice bellows function to it. And the tricuspid valve has normally got quite a larger coaptation point. You see it's almost been stretched apart. It's just like just the tips are just sort of joining rather than having a nice coaptation of a good few millimeters. And that means there's probably some significant TR, which I'm sorry I'm not going to show you, but you get this massive RA dilation with, again, the intratracheal septum pushed over to the left, suggesting a sort of volume overloaded system, which is all part of the cor pulmonale. But anyway, this isn't to talk about the right ventricle, but I can't go past without talking about it. And I guess when we talk about RV dysfunction, I stole these slides from the RV dysfunction talk. You'll notice when we start to talk about how to protect the right ventricle when you've got someone who's sick, we talk about treating the underlying cause, avoiding fluid overloaded, choosing a catecholamine that hopefully doesn't sort of overload the right ventricle. So I don't use huge doses of noradrenaline because that's got some venoconstriction and that provides maybe excess preload to the RV, things like that. Look at pulmonary vasodilators. But the main thing here to talk about is the ventilation and the pulmonary vasoconstriction, because this guy had a cardiac arrest because he was intubated. And that's the best I can come up with, is that he was doing okay, he was up on the ward, went to theatre, had some sedation, and then they intubated him. When they put him on positive pressure ventilation, that caused the RV to expand and put him into an acute cor pulmonale state, where the LV couldn't fill because of the interventricular septum being pushed over. Maybe this guy might have been a little bit a bit underfilled for being in hospital for a week or so. And maybe he's also known to have some OSA, so he's was borderline hypoxic. Maybe he's got some atelectasis, he had that soft tissue infection around his tummy, which meant that he wasn't breathing up. So he's already a little bit hypoxic. Risk of hypercarbia because he had OSA. And then you don't ventilate him properly as you're sedating him, and becomes acidotic, and all of that causes reflex pulmonary vasoconstriction. So suddenly with the increased pressure in the chest, and I'll show you some images, we look at overloading that right ventricle very, very quickly. And I think this guy was in a precarious position with his dilated right ventricle to begin with, and then you intubate him, and you're not ready for it, and you cause a cardiac arrest.
Sorry, Sam, was that the cardiac arrest immediately on induction?
Yes, absolutely. It's on induction, on intubation, so it's shortly after intubation.
So why wouldn't that be, it could also be a drug effect?
Absolutely. But I guess it didn't happen straight after they gave the medication and he dropped down, but certainly that would have contributed. Not saying it wouldn't contribute, but it's, so in case you didn't hear that, the idea was that the induction would also have caused some myocardial depression, which of course it would. But I guess the point I'm trying to make is that the patient was in a precarious position because that right ventricle was enlarged anyway, and it's important to understand heart-lung interactions. And I think with 2020 hindsight for the anaesthetist, I'm sure they'd like to have maybe looked at that echo in a little bit more detail, understood that an RV at risk, you've got to think about how you're going to anaesthetize these guys very carefully. I think that's all I'm trying to say. So why don't we work through some of this together? So just an MCQ. So positive pressure ventilation can cause which of the following effects on the heart? Okay, can it increase the LV preload? Can it increase the RV preload? Can it increase the RV afterload? Cause the interventricular septum to bow to the right? Or lung underinflation and hyperinflation both reduce pulmonary vascular resistance? Ben, you're our respiratory guru. I know you're just starting, but we're going to work through all of this, but just tell me what you think about this as we go. So,
yeah, no worries. First of all, just for that case, it's very brave taking someone of that size to theatre. I think there was a lot of looking back and scratching heads. 2020 high science, a wonderful thing. I see those patients in sleep clinic, and they are a walking disaster when they're conscious.
Absolutely, and I think it's just having that idea of, I talk about, the at-risk RV, and these patients can look fine, but as soon as they become, hypoxic or hypocarbic or acidotic, or, you set the PEEP wrong, and they can get into trouble really, really fast. And this is a great example of that. And it's all heart-lung interactions, right? So what's going on, some of this relates to our guy as well. So increased LV preload. So if you increase up your pulmonary pressure ventilations, can you increase your LV preload?
So I think that's the hardest one of this lot. Except for the bottom one. I think that's
exactly what I was thinking. Is I shouldn't have put that first. I was just thinking the same thing. Maybe we'll start with the easy one. What do you think about the increased RV preload?
No.
Okay.
I don't think it will. It should reduce the RV preload because.
But increasing RV afterload.
So it could because you're increasing your your transpulmonary and transpleural pressures.
Very nice. So exactly, that's the correct one. Just run me through. So the interventricular septum going to the right.
I can't logically have that make sense unless it's no.
it's going to go to the left, isn't it?
Yeah, exactly. Yeah.
Increase your RV afterload, and you're actually going to reduce your RV preload. You actually hyper-expand your RV, and I'll show you some examples, and that pushes it to the left. Beautiful. And then lung underinflation or hyperinflation can both reduce pulmonary vascular resistance.
Well, you can't have underinflation and hyperinflation both do the same thing.
I was going to say, yeah, and maybe that's I've written a bad MCQ. I guess what I was trying to get is that there's a sweet spot in there. Because if you underinflate, you're going to become hypoxic and hypercarbic, and you'd cause some reflex pulmonary vasoconstriction.
If you overinflate, you're going to have collapse. Like
but that's increase the pulmonary vascular resistance that way. That's what I was trying to get to with that. So yeah, 3 is the right answer. You'd increase the RV afterload.
If you start normal before heart, then that would be the case.
Yeah, agreed. Yeah, it might not be the best MCQ. Luckily, the exam doesn't have MCQs in it. But it was just to stimulate thought. So we'll just start off with the most simple explanation I've got, and then we'll gradually get more tricky with some cases. So positive pressure ventilation, you stick a tube in someone, you blow air into their chest, you're going to increase the lung volumes, you'll increase up their airway pressures. That will, if we think about the pressure inside the chest, normally the intrapleural pressure is a bit lower. If you increase up the pressure in the lungs, that will increase up your pleural pressures, intrapleural pressures. That will force your diaphragm down, which means that if it's in closed space, you're going to increase your pressures in your abdomen as well, but maybe not as much as your chest. So my very simplistic mind works on, we're just going to work our way around the heart. So we'll start off with the right atrium, okay? We'll talk about preload into the right side of the heart. So to have flow going into the right atrium, you've got to have a pressure inside the IVC that is greater than the pressure inside the right atrium. So you've got to have a pressure difference for there to be flow. If you stick someone on positive pressure ventilation, you'll increase your pressure in your thorax, your right atrium's in your thorax, so that goes up. You will also squash the diaphragm down a bit, which will increase up your pressure in your abdomen, so that your intra-abdominal pressure will go up a little bit, but not as much as the right atrial pressure goes up. So I'll show that again. So it starts off being like that, and the difference is the preload to your right side of your heart. If I then put you on mechanical ventilation, don't think about inspiration and expiration just yet, just average mean airway pressure goes up. It goes up like that. So the difference is then smaller. So it starts off like that, bigger difference, to going like that, smaller difference. So you reduce your preload to the right side of your heart. With the RV afterload, as you were saying, Ben, if you increase the pressure inside your chest, open up the alveoli, you're going to squish some of those pulmonary vessels, most likely. That's not 100% true, but we're being simplistic. But you can squash some of those, which means that you will increase up your RV afterload. It's harder to get blood out of the right ventricle when you've got an increased pressure inside your chest. That will therefore reduce your left-sided preload. So your left-sided preload will also go down because you've got less blood coming out of your right side of your heart. And then the next tricky one to explain is the LV afterload. So LV afterload, again, you've got to have I'm going to use the Place's law to explain this, which is where you talk about the pressure times the radius divided by the wall thickness. That's how we learn in med school that that's the definition of afterload. So again, that pressure difference is the pressure inside the left ventricle to in the intrapleural space, and it's that difference that is the afterload. And if I put someone on positive pressure ventilation, I will obviously increase up the pressure in the pleural space. I will also increase the pressure in the left ventricle, but because it's got a thick wall, it doesn't go up by quite as much. So again, it started off like that, big difference, and then it goes up to like that. So again, a smaller afterload. And so that's why, Mrs. Smith, 80-year-old lady in APO from her non-STEMI, she looks so much happier when you stick her on non-invasive ventilation because you increase up the pressure in the chest. We're not forcing fluid out of the airways, as I used to think in med school. It's more like you're reducing the afterload, you're making the heart work more efficiently, which means that you can offload the system, which means you don't get so much pulmonary edema. And that's where you reduce your myocardial oxygen demand. So she looks happier when she's on a non-invasive. Yeah? that all make sense? Because that's the nice, simple way of thinking at it. I think in most exam scenarios, if you were to write that down, you're going to get the majority of it done. And now we'll get to the bit that I find really, really hard to explain, which is the respiratory variation. Okay. The last thing we should say is, before we move on, is that this is dependent on the underlying physiology. So I describe as, so us sitting here with hopefully our normal hearts, we are preload dependent, which means that if I intubate you, Ben, when you're having your appendix done, I'll give you some medications. We'll ignore the effect that that has on your heart to begin with. But as soon as I intubate you, you are preload dependent. And that means that the predominant effect on your cardiovascular system will be when I affect your preload. Because I reduce your preload, this is one of the factors that causes your cardiac output to fall and your blood pressure to reduce when I intubate you. Now, if I then, instead of intubating you, I'm actually intubating Mrs. Smith with non-STEMI and APO, and non-invasive isn't working, so I'm having to intubate her. She is afterload dependent, which means that she is going to have the same effect that I had on you, which is reducing your preload, but she's more afterload dependent, which means I'll reduce her afterload, so her cardiac output and blood pressure might actually go up because she's more affected by her afterload than her preload. I think with our gentleman that we had before with his RV at risk, he's the guy that I've increased up his RV afterload, and that's had the major effect on him with his RV at risk. He's got acute core pulmonale and his cardiac output's horrifically dropped, and that's because he's got RV dysfunction. So the effect of the positive pressure is going to depend on what your underlying physiology and pathophysiology is. Please interrupt me at any stage, because I find this very tricky to explain and understand. So please, if I get anything that you need me to repeat anything or try and say it in a better way, let me know. So the heart-lung interactions in terms of the critically ill, I think the areas to consider, or when I'm seeing patients who have these kind of clinical features, this is when I reach for the echo probably most readily. And I think those sick patients on ventilators, I'll admit, I don't scan every single one of them. I'm selective. And the ones that I try and scan are the ones who are on significant catecholamines, or ones who have got heart-lung interactions. So I'm trying to differentiate causes of why they're hemodynamically unstable, or I'm trying to look at how they're interacting with their ventilator. And that's particularly if they've got LV failure and I'm trying to get them off the ventilator, if they've got any kind of RV at risk, and if they're hypovolemic and I want to see if they're volume responsive. You know, those are the big ones to think about heart-lung interactions. So let's talk about the LV and weaning. Lewis, I do apologize. I think you probably heard this lecture before, so forgive me for you hearing it again, but talk us through this. This, again, is not the best MCQ in the whole world, but talk me through a little bit. So which of these patients would you think would most likely benefit from being extubated to NIV? And I don't have a lot of evidence to back this up. This is, I guess, a bit of personal stuff, but just to stimulate debate. So Lewis, have a think. I hope they come through okay.
Yeah, I think so. So I guess the question is, who is the most likely person to benefit from remaining on intermittent positive pressure ventilation?
Very nice. Because what's that going to do to their LV that I'm talking about? Just to take me to the next step for everyone's benefit.
Yeah, so the benefit comes from the reduction of LV afterload.
Fantastic, thank you very much.
So the person with the least good LV is most likely to benefit.
Fantastic, excellent, thank you.
Just eyeballing that looks like A.
Beautiful, beautiful. The reason why it's not a great MCQ, and I've meant to change it for the last 4 times I've given this talk, is that B is someone who's got a bit of an enlarged RV. And potentially if you extubate that person, and I guess they've got hypoxic or hypercarbic, there could be the argument that you'd want to use NIV to maybe help prevent atelectasis, and that might be good for their RV. It was just meant to stimulate debate. Thank you. And the other two, C was someone who had a relatively normal heart, bit of hypertrophy. I don't really think that person needs to be thought about too heavily just from that echo image, unless they were hypervolemic, and I guess that's another talk in itself, how to use echo to define hypervolemia. But that's got an interatrial septum that's wiggling around, so just on that one picture it doesn't look hypervolemic. And D was someone who sort of looks hypovolemic, who's got that kissing ventricle sign, and again, an interatrial septum that's wiggling around, probably someone that doesn't have a horrible problem with afterload, maybe. So yeah, great answer. So the weaning, just to be clear, so when we're doing, if I think someone's got an LV that looks like this, or I think they might be a little bit fluid overloaded, these are the guys that I do spontaneous breathing trials on. I don't do them on everyone. I do them on people who've got, excuse me, sorry, I was trying to, I do spontaneous breathing trials on those who I think are potentially fluid overloaded, and sometimes I find that intravascularly fluid overloaded, so risk of pulmonary edema if I extubate them, because they've got raised left atrial pressure, or people who've got bad LVs. Those are the ones I most commonly do a spontaneous breathing trial on, and by that I mean just drop them down to 0 and 5, and just have them on CPAP, low CPAP, or turn off their tube compensation. And that, again, I don't have a lot of evidence behind that, but it just makes physiological sense to me. So, and that's because when I do that spontaneous breathing trial, I'm going to increase up their LV afterload. I'm going to try and simulate as closely as I can what it's like when they don't have any support. So I'm going to increase their work of their breathing. I'm going to increase their adrenergic stress, and I'll decrease their intrathoracic pressure and therefore increase their LV afterload. And that means I want to see what happens. Do they struggle? I make sure I talk to the nursing staff. I think it's really important if I do this to make sure the nursing staff are looking at these guys. I'm not looking for desaturation. I'm looking for signs of increased work. So do they become tachypneic? Do they look like they're sweating? Is their heart rate going up? It is not about saturations. It's about how that patient looks. And if they look like they're struggling, they're not ready, I'll try and diurese them, more support, something like that. But if I think they're okay, I will extubate them then onto CPAP if someone's got an at-risk LV. And as I say, I don't have a lot of evidence to support that, but I think it makes physiological sense. So it's almost like, as I call it, a hemodynamic stress test. I try these on patients with a limited cardiovascular reserve, and I'm trying a slow wean. I look for signs of raised left atrial pressure. If you're doing an echo before and after, you can look and see if there's studies have looked at a rise in an E on E prime to be suggestive of it, or particularly an increase in the E wave, suggesting increased left atrial ventricular pressures. More B lines, I think that'd be great. All of those could be potential signs of failure. So not for everyone, but think about it on those who may be at risk. Okay, so that was the weaning. We'll talk about the RV afterload. I think we've gone through this with the at-risk right ventricle. I'll just talk more about the actual alveoli and how that affects the pulmonary vasoconstriction. So again, I'm probably teaching the current audience to suck eggs, but let me brush through this. So I guess when we're trying to ventilate patients, we're trying to stick them on that best sort of compliant portion of the curve. So that's why we give patients positive pressure ventilation. We try and open up the alveoli. We try and optimize their PEEP. And we all know that you're going to have some areas which are more in the more dependent areas, which may get a little bit more atelectasis. We're going to have some areas which have better, they have worse sort of VQ matching. They're more easily distended alveoli at the top of the lungs or anteriorly maybe. And these patients can have overinflated lungs compared to sort of the majority. All we can really measure is the average of them when we're talking about compliance. And if we overventilate these guys, we can actually push these guys up that curve, and we can get more people who are at the top part of the curve, and that's when we can talk about overdistension. And these patients who have got RVs at risk, this is a really, really bad thing. So I think for our patients who have RV dysfunction, similar to those who've got head injuries, I guess, if we increase their pressures too much, it can be a bad thing. Prevents venous return down from the brain for those with head injuries, and it prevents blood coming out of the RV for those with bad RV failure. And I mean, this is, again, you probably all know this, just to show a picture of a study we did and 10 poor pigs that we took who were they were in another study, but I got to borrow them at the end of it before they were euthanized. And I just had them on 0 PEEP, and then I just did this escalating PEEP maneuver. And they had nothing wrong with their lungs, but it just obviously shows that when you go to ridiculous levels of PEEP on pigs with normal lungs, it blows out the RV. And these are intracardiac echo pictures. So this is the right ventricle on the right side of the image. You can see an RV that looks smaller than the LV. And here you've got an RV that's completely dysfunctional, is not doing well, this pig's got a blood pressure of about a map of like 15 or 20 or something when it's normally closer to 55, and you've got that septum is flattened. So just as you'd expect, too much PEEP, overinflate the alveoli, stop blood leaving the right ventricle gets overdilated, it can't cope, and it stops working because it's got nowhere for the blood to go. And if you don't take the PEEP away, the pig dies. In addition to that overinflation, so we've got to optimize our airway pressures, that's important. We've also, at the other end of the spectrum, got to avoid acidosis, hypoxia, and hypercarbia, because all of those things, we've got a reflex in our blood vessels in our chest, that if they think if there's an area of pneumonia, for example, in your left middle lobe and in your left lower lobe, then it becomes acidotic, hypercarbic, and hypoxic in that localized area. That causes reflex pulmonary vasoconstriction, so blood gets diverted to your nice happy alveoli, and you'll improve your gas exchange. Problem is, if you get sick and you become, if everything's hypoxic and hypercarbic and acidotic, you can cause problems everywhere. So again, for the RV dysfunction patients, we try to, maybe the ARDS patient, I don't allow permissive hypoxia and hypercarbia and acidosis to the same extent that I would for someone who's got a relatively normal heart. So that's why it's really important with ARDS patients to have a look at their heart before you start setting the ventilator. I have no idea what an optimal PEEP is, but I do think it's different for a group of patients. So I think trying to set the PEEP with staircase maneuvers and recruitment maneuvers, I know it's not maybe in vogue because of the ART trial, but I think my argument would be you've got to choose your patient. And the patients you've got to choose are the ones that've got at-risk hearts. And if you're going to do it, have a look at it with an echo, and you try and find a sweet spot that's based on cardiovascular status as well as what your compliance is in your lungs. And that's what this is all about, as I'm sure you know. If you've your pulmonary vascular resistance, there is a sweet spot, and that is different for every patient. I think probably the majority of patients on ventilators, it probably doesn't matter. I don't think the curve is as bad as this. I think it's probably a bit flatter, so you've got a wider sweet spot. But there's a group of patients that you absolutely must think about this, and they're the ones that are sick on. I just have anyone who's on a PEEP greater than 10, I think you have to look at their heart and have to do stepwise maneuvers and see what the effect is on their heart. I don't just follow the ARDS protocol and someone who's got a PEEP of 10 gets an FI2 of 0.8 or whatever. I think it's got to be a bit more individualized than that. And again, maybe that's a talk in itself. I'll just skip this if that's all right. I don't think we need to talk about protective ventilation. Other to say that, again, RV's at-risk prone ventilation, because you can improve your oxygenation, you can improve your compliance, and that can help your RV. And that's one of the ideas that particularly Antoine Villemarin talks about, is he's a big proponent of doing prone ventilation in those with RVs that are at risk when they've got ARDS. Okay, so show another case of an asthmatic who came through a few months ago. So he's 40 years old. He's had previous intubations, unfortunately, because his asthma is not great. Still smoking. He's not a quitter. And he gets admitted on a Monday from ED. He's got flu A. This is life before COVID, and he's breathless. And you can see this guy's on a not insignificant amount of support. He's got nitric oxide going. He's not on a huge amount of cardiovascular support, but he is on isoflurane to try and help his cardiovascular resistance. And he's pretty tachycardic from all the salbutamol and stuff we're giving him. And you'll see that he's got some form of potential gas trapping in there with his expiratory limb not reaching the baseline. And a big difference between his peak pressures and his alveolar pressures. So this is him on Monday morning. Because he's on a considerable amount of support, I think it's not unreasonable to have a look at his heart. You'll notice this is all subcostal imaging. I'd love to do a little tutorial sometime on the importance of this, because we couldn't get any images from anywhere other than in his subcostal area. And you'll see that, I know these are terrible pictures, right? But you can still get the idea that the right ventricle is not horrifically dilated. And we can see here that off axis, but the right ventricle doesn't look bigger than the left ventricle. If you, from the subcostal, if you sort of go off axis and just rotate it 90 degrees and look to the patient's left, you can get a short axis view, so you can still try and assess things like, you know, maybe the RVOT profile, looking for your V wave or your pulmonary acceleration time. You look at your RV, LV size. And this guy's not on a huge amount of oxygen support. CO2 is the main problem. He's got a normal renal function. He's kind of improving on day 1, 2, and 3 from the Monday, Tuesday, Wednesday. Okay? Thursday, wheels fall off. Come in and we find that this guy's deteriorated. And he's now got pretty good going gas trapping. And he's got FiO2s are up to 1. He's got fevers. He's got sputum coming up. We're worried about infection, thinking potentially the left lower zone, not quite as good lung markings behind the heart. His oxygenation's worse. He's acidotic. He's worse hypercarbia, and he's got acute renal failure. And that was the acute renal failure that says, well, hang on a minute, we've got to go and look at his heart. You know, why is he suddenly got the acute renal failure? Is it just the septic process, or could it be his heart? And sure enough, I think we look at this and compare this to the 2 days before, and you can see with the increased level of support, with the gas trapping, with the worsening hypoxia, hypercarbia, I think that's the cause of his right ventricle becoming acutely overloaded. And I think that changes the way that we manage him. And that's, I think actually the first image I took is probably from this day, is actually that's when I started the pulmonary vasodilators. You know, that's when we got to start looking at trying to protect his RV as well as getting his oxygenation is suddenly much more of an important process. So that's just having a look about Monday compared to 3 days later. Images not perfect, but I still think you've got enough information to help guide your therapy, and which is so important to know about the heart-lung interactions. Okay, now it starts getting tricky. So let's go through hypovolemia and assessing for fluid responsiveness is, and also for tamponade physiology, I should have said, is all about then the variation that goes on as we breathe in and breathe out. And this is the bit that I find quite hard to explain. Very kindly, Andrew Hilton, one of the godfathers of critical care echo in Australia, I think he's let me steal these slides. I think I asked him back in 2018. I'm not entirely certain whether he still knows I'm using them, but I'm hoping he'll be okay with this because these slides are unbelievable and they're in his textbook. And so I just want to say a big shout out to Andrew Hilton for letting me use these slides, because I think they are the best explanation I've ever seen. And I'll try and do them credit. Okay, so we've got a heart system that looks like this, and we'll try and use it to explain those respiratory variations. When we breathe in and out, whether it's on mechanical ventilation or spontaneous, you get changes in lung volume. That's going to lead to changes in intrathoracic pressure. We are going to have some form of serial interdependence, as in what happens below the diaphragm will have an effect on above the diaphragm, but also we have parallel interdependence, as in what happens on the right side of the heart is going to affect the left side of the heart because of ventricular interdependence. Let's start off with someone who is spontaneously breathing, and you're at end expiration. We talked about some of the pressures in the cardiovascular system already, and he calls it mean systemic filling pressure. I know several doctors who would argue that that's not a thing, but we'll ignore that for the time being, and we'll just say that there is a pressure. You can call it whatever you want. We'll call it mean systemic filling pressure here for the case of this. And we've got right atrial pressures, right ventricle pressures. We've got pressures in your pulmonary veins leading into your pressure in your left atrium, and then you've got your pressure in your left ventricle, and you've got your intrathoracic pressure. At end expiration, we have blood that comes from our mean systemic filling pressure from our IVC into our right atrium, and that's because the pressure is bigger, it's got a bigger P versus your right atrium, and that's how you get blood flowing into your right atrium. You have pressures in your right ventricle that are bigger than in your pulmonary system, which is how the blood can flow out, and that causes blood to come into your left atrium, left ventricle, and out into your aorta, into your systemic circulation. Okay? The venous return from your systemic circulation is dependent on the pressure in your mean systemic filling pressure being greater than your right atrium. The venous return coming into from your pulmonary system, you must make sure that the pressures in your pulmonary system, your pulmonary vein pressures, are greater than in your left atrial pressures. Okay? We do have a pressure in here. You'll see the intrapleural pressure, or intrapericardial pressure, which we're going to say for the time being approximately equals your intrathoracic pressure. And that is not the case, obviously, when you have tamponade. We'll come on to that in a minute. Okay, you're going to breathe in. So as you breathe in, the effects that you're going to have is you're going to reduce the pressure in your right atrium. So as you breathe in, you're going to reduce that pressure because of the effects of the reduced pressure in your intrathoracic cage. We're going to decrease that diaphragm a little bit as we do, which might increase the pressure in your IVC, and that means that you're going to increase the return to your RV, okay? So you're going to increase the venous return from your systemic circulation. So increased RV preload. The effect on the afterload has probably got something to do with your underlying condition, but the idea might be that as you breathe in and you open up your alveoli, that's going to pull open your pulmonary vasculature. It might reduce your pulmonary vasculature, which means that might help the blood flow out of your from your RV, because you've got an increased preload into your RV. That might increase out the blood flow, as well as maybe a reduced pulmonary vascular resistance, and we can argue a little bit about that. But we could say that we might get an increase in your RV afterload. So increased RV preload, increased RV afterload. Depending on the situations, you may cause a little bit of movement of that septal shift over to the left side of the heart, again, dependent on your pulmonary vascular resistance changes. And so that's going to, we don't know exactly what happens to the venous return from the pulmonary system, and it can go up or it can go down. But in particular, if it's got some form of increased shift from of the interventricular septum, that can cause reduced compliance for your LV. So if you do have shift going over, you'll definitely reduce your compliance, and that will cause a problem with getting the blood out of the ventricle. Okay, so you can get this decreased preload from that reduced compliance, the reduced size of that left ventricle. That will certainly cause reduced preload, and because of that poor compliance, that can also affect your afterload. Okay, so the increased afterload that you can get from as you breathe in, the reduced pressure. We talked about the increased pressure reducing your afterload. The reduced pressure can have the alternative effect. So the increased LV afterload with the decreased LV preload. Okay, and this is an example of that. So if we can see, if you just look at the apical four-chamber view I've tried to take of this patient, we can see the right ventricle here on the left, and just look at this septal bounce. And I've tried to take 4 or 5 cardiac cycles, because at the beginning, the septal bounce at the beginning is different from the septal bounce at the end. And that's as that patient breathes in, particularly someone with COPD, asthma, really increased work of breathing, you can get a difference in the septal shift. And that's what that's meant to be an example of, okay? It's subtle. We can see it with things like constricted pericarditis as well. Something that subtle is how you pick up that. And that can be seen by this change with inspiration, that reduced LV preload and the increased afterload. You can get this reduction in your left atrium to left ventricle flow and a reduction in your cardiac output. Septal shift with inspiration. Okay, so the normal variation you'd see with someone spontaneously breathing is with inspiration, you get that reduction in that flow across the mitral inflow and a reduction in your blood pressure. And that's often for preload dependent hearts, I guess. Let's think about tamponade now, right? So tamponade, we know the clinical features of it in terms of hypotension, pulsus paradoxus, raised JVP, tachycardia, and low cardiac output. Big one that's missing off there is shortness of breath for me, so particularly worse when they lie down flat. So that's one of the first things that I ask for when I'm asked to see someone with possible tamponade is, how are they clinically? Is the clinical diagnosis, are they short of breath? Okay, so we've gone through all this in terms of the increased systemic return, decreased intrathoracic pressure as you breathe in, increased lung volumes. Maybe the pulmonary venous return, as we said, is going to depend on your underlying state and your pulmonary vascular resistance. But if we've got that increased flow, increased fluid in the pericardium, that kind of pericardial restraint, then you're going to get this leftward shift that comes in, the ventricular interdependence, particularly with inspiration, spontaneous inspiration, all right? And that's going to lead to an exaggerated response. So in tamponade with spontaneous ventilation, we can often see this pericardial restraint, which means that we would impair our ability to we won't see that change maybe that we saw in terms of the reduction in the right atrial pressure that we saw. And we're going to even impair that ability as we then decrease our diaphragm. It's going to actually, maybe it's not going to increase our preload very much, possibly at all, in which case you can see the decrease in your systemic venous return. With that, you're going to have a reduced septal return, that change, the pericardial restraint, so any kind of increased pulmonary vascular resistance is going to cause that increased RV afterload, and you can get the septal shift bouncing over. So decreased RV preload, so you've got a decreased heart volume, you can maybe have this increased pulmonary vascular resistance, and that's where you might see that septum being pushed over. That's going to probably reduce your pulmonary venous return, that will impair your ability to get blood back into that left ventricle, worsening compliance, and that's how we start to get impaired output, which is where the pulsus paradoxus starts coming in, and the decreased cardiac output. Because you've got, as well as that increased pressure inside the heart, from this increased pressure in the pericardium, that's also going to contribute to that reduced return. Okay? So this is an example that we've got of someone with a malignant pericardial effusion. This is one of Andrew's cases. And we can see this huge respiratory variation that's going on in terms of the tamponade physiology of this patient who's spontaneously breathing. Once he's drained the effusion, we can see that that respiratory variation is markedly improved. And I can't remember if we've done, I think we've done tamponade physiology. The big one that we look for, the numbers change. We talk about echo diagnosis of tamponade, including significant variation across the mitral and tricuspid valve inflows. And we typically, I have about 25% change in the LV mitral valve inflow and about 40% change in the tricuspid. But I think the numbers do vary, and they talk more about 60% in, I think it's the ASE guidelines. But I think I'm just trying to remember there's significant variation across the atrioventricular valves. Okay, what happens with positive pressure ventilation? It feels a little easier. I think you at end expiration, your venous return, venous return, you have increased positive pressure. As I said, that kind of reduces your preload into your right side of your heart. That means that you get a reduced output to your left side, so you reduce the LV preload as well. We can increase our RV afterload, and we can reduce our LV preload. Okay, so if we say that the venous return from the systemic circulation compared to when you're spontaneously breathing, it probably stays about the same. And for the pulmonary system, maybe stays about the same for this exercise. Okay, now when we breathe in, okay, or positive pressure comes in, increased pressure in your right atrium, diaphragm goes down, we're going to reduce our preload into our right ventricle. We're going to increase our RV afterload, as Ben was explaining to us before, because of increased pressure squashing the pulmonary the pulmonary capillaries. And that means that we are going to affect our preload to the left side of our heart. And this is where, with insufflation, with the blood volume that's sitting inside your chest, with the insufflation, that could, I think this is where I'm going to disagree sometimes with Andrew, but that can force blood into your left side of the heart. I think if then you look at the end of inspiration, you can actually then get a reduction. But for the sake of this argument, increased pulmonary pressures, forcing blood out of the pulmonary vasculature into the left side of your heart. So you can get the increased LV preload. And he's saying it depends on your RV response, and I think it depends on your pulmonary vasculature as well. If you've got that RV septum that's pushed over because of the increased RV afterload, that will impair the compliance of the left ventricle, impair filling, and impair its ability to put out. As he's saying that again, it's decreased LV afterload because of the increased pressure as we discussed. So in terms of respiratory variation, you can get an increase in cardiac output with inspiration because of the increased preload to the left ventricle, and I think that is dependent on your RV as well as your pulmonary vasculature. So we use this for fluid assessment by looking at using your pulse wave Doppler and your apical 5-chamber view. Make sure your Doppler alignment is optimized and make sure you've got a decent closing click. And what you're looking for is I use a percentage variation of at least 20%. The literature varies. It talks about a variation in inspiration to expiration of anywhere from 10% to 15%. I think there's a gray zone in there because I don't think this is that easy, and I don't think it's as easy as they say in the literature sometimes. So that's why I use a fudge factor. And so I use 20%, which is what was recommended to me by Michel Slama, who did a lot of the work in this, and he said, yeah, it's tricky. So when, from a statistical point of view, it might suggest that 10% is the way forward, but he says from a practical point of view, using 20% is the way to go. But you can see this big variation that happens with respiration in your apical 5-chamber view. If you get a big variation of greater than 20%, you could suggest they're fluid responsive. If you want to go that step further to check, and I always recommend we should do, we can do a passive leg raising maneuver. And as what we can look to see if there's that change, if there's a big change of 20%, if the patient is fluid responsive, when you do the passive leg raise, you should reduce that variation. And as well as doing that, I will also check the VTI. And I have the same number in mind. I want to see the VTI changing by 20%. And this is where imaging becomes really important because you start moving the patient around, even with breathing. If you can imagine you've got that pulse wave gait and that LVOT, it's going to move with respiration. So when I'm doing this passive leg raising maneuver, once I put my hand on their chest and made that measurement, I don't move my hand. I have it, I'm like holding the echo probe, clamping my hand down on their chest, and I keep my hand very, very still by using my other outside my hand as an anchor point. And then you can do the passive leg raising maneuver, which moves their, so if you've got the bed at say 30 degrees with their legs flat, you then move them so their head of their bed is then flat and their legs are ideally 45 degrees up. With the hill run beds, I find that quite tricky, so I often sort of just tilt the bed a little bit as well. And here we can see someone's VTI went from 13 to 14, so I did not see that massive increase of 20%, so I'd say this guy is not fluid responsive. Okay, and just as an aside, just make sure you optimize your image. You'll see I've got the baseline of that Doppler profile at the top of the picture. What I'm interested in filling the screen, there's 3 cardiac cycles in there. I'm carefully tracing. I probably do 2 or 3 and take the average, and I make sure I'm seeing that closing clip. Okay, so making your imaging as accurate as possible in the same place. Don't take your hand away and put it back on. You know, you need to do it, you need to try and keep it in the same spot. And I wait about 45 seconds or so before I make the measurements after you've tilted them up. So that's about it, I guess. Hopefully a few minutes for questions, but I think the heart-lung interaction is tricky to understand. It's really important, and I use it mostly to try and determine, to tell me when to do an echo. When is it important? We don't need to do full echoes on everyone, but there is important to do them on some patients, and those are the ones that I think might have difficulty weaning because they've got a bad diastolic dysfunction or fluid overloaded or LV dysfunction. We need to look at the right ventricle, and those are at risk of the right ventricle. We need to consider the changes in the afterload. In terms of setting the ventilator, optimizing that PEEP in ARDS patients if their right ventricle is at risk. Those who are fluid responsive, as we just showed, and of course, tamponade physiology, we should be able to explain why we see the changes there. So that's it. Thank you very much for having a listen to all that. I just wonder if there are any questions.
Yes, I've got one.
Sure. Can everyone hear Louise if she's asking questions?
So you mentioned that you were uncertain about the effect of IPPB on left ventricular function.
Yeah.
Yep. But could it be a situation where if you squeeze the pulmonary veins, the left atrium fills, but on the other hand, the septal shift makes it more difficult to fill the left ventricle. Therefore, depending on which of those is more important, you will get a change in your left ventricular output, which is what the important thing.
Yes, I think
So I think
nicely,
that-
very nicely said. Yeah, I think that's very
So that
reasonable.
wasn't actually a question, it was
More of a
kind of
comment.
working through.
Yes, absolutely. I completely agree. I think that's a nice way of putting it. It's quite a tricky subject, this, I find, so forgive me if it wasn't obvious as I was going through it. I have to think about it. I've been trying to teach this for a long time and I still don't think it's perfect. But I hope it was useful. I'll obviously put this up on the website and I hope it's useful. Were there any other questions?
No, that was great. Thanks, Sam.
Fantastic.
No, it was good.
Great, thanks guys.